took over the GP practice of Harold Shipman, a notorious serial killer who did a lot of damage to that region.
And they were angry. And the reason they were angry, because they think he's murdered somewhere between 250 to 500 people. It's one of the most prolific murderers in the world. Well, why should I trust you when we trusted Shipman? I said, I am never, ever going to be a GP because there is absolutely no way I'm going to have that kind of abuse. Are you allowed to turn the screen so that I can see the information about me? This is your information. I've got nothing to hide from you, so why don't I share this information so that you can see what I'm thinking? And we can build what I call a partnership of trust.
Emergency. Come down to trauma immediately.
SATs were down to 70%. The patient was going from grey to blue. You see the chest rise, and as the blood pressure starts to come back, there was this sort of sense of relief around the room. They're worried about things like artificial intelligence. I don't believe so. I think there's something much, much more powerful than artificial intelligence, and I call that human intelligence. Partnership of trust.
Today's guest is Dr. Amir Hannan. He hails from Manchester and is a general practitioner. He took over the GP practice of Harold Shipman, a notorious serial killer who did a lot of damage to that region. He talks about some of the adversities and challenges he faced by trying to rebuild and regain the trust of the patients in that region. He also talks about how to make the most of being a doctor and utilizing this responsibility whilst enjoying the process along the way. We also talk about the future of the NHS and why we struggle to retain so many doctors. He is also the chair of the World Health Innovation Summit and so has a huge influence and impact on how we can change medicine globally. I feel like many medical students head into clinical years and they're really excited. They want to say, I want to be a neurosurgeon, I want to go into orthopedics, I want to do this and that. But for some reason, when it comes to general practice, many people can be a bit too sheepish to admit that I'm really into GP. And so, as somebody who is a GP and a very experienced one, why not GP? Why should you be proud of going in and saying, I want to go into general practice?
So I come from a medical background. Both my parents were both GPs. And back in those days, we didn't have mobile phones. So as a result, even as a young child, patients in those days, GPs were on call 24 hours a day, 7 days a week. And patients would ring the house when they needed the doctor. So I would sometimes pick up the phone, I remember as a 7-year-old child, and someone would say to me, I'm having chest pain. And I would say to them, I think you need to put the phone down and dial 999. And the patients would say, are you sure? Yes, my daddy has said to me that if you're getting chest pains, you should dial 999 and call for an ambulance. So I grew up in a GP household. I saw all the pressures, the tensions. And when I decided to go into medicine, and that's an interesting story in itself, but once I decided to go into medicine, I remember as a second-year medical student coming home, and my father was pacing up and down. It was about 2 o'clock in the morning. He was pacing up and down on the corridor. And I came out and said, Dad, what's wrong? And he goes, a patient has rang up. He's come back from the pub. He's 17, 18 years old. He started with a sore throat an hour ago. And he's insisting on a visit, and he wants me to come out and see him now, otherwise he'll sue me. Now, my father had diabetes, he had complications, he couldn't drive at night time, and he was pacing up and down because he didn't know how to do this visit, and he was worried that this patient would sue him. My response to that was, Dad, see him in court. But my father's generation was very different. And they didn't do that. They were always there to serve patients. And he said, no, I must go. And I said, all right, Dad, I'll drive you so that you can go and see this person. And took him on his visit. I came home and I said, I am never, ever going to be a GP because there is absolutely no way I'm going to have that kind of abuse. So actually, I chose not to do general practice at the start. As I went into my clinical years, I remember very well as a third-year medical student, observing a laparotomy, and there was a surgeon who was a bit like Hitler, a short guy, who was busy operating. And in the middle of the operation, suddenly all the alarms started going off. And I turned to look at the anaesthetist, and the first thing the anaesthetist did was switch off all the alarms. And then he got his trusty stethoscope out, put it under the drapes to have a listen to the chest, and then went round to the feet and sort of flicked the toes. And then he went back, put some medications into the patient, and then about sort of 5 minutes later, switched all the machines back on again. And I remember at the time the surgeon said, "Is everything okay?" And he said, yes, it's fine, continue. And I went up to the anaesthetist afterwards and I said, "What was that all about?" And he said, "Oh, I come from an era before we had computers and things, and I find that when the alarms start going off, I can't think for myself. So I switched the alarms off and did what I needed to do." Of course, he also said that you're not allowed to do that, but, he was from an old era. For me, that was the magic of medicine. I just thought, wow, I've just seen someone incredibly inspiring who's used his his fingers, his knowledge, seeing things, touching things, feeling the pulse and whatnot, and working out what to do. And that inspired me to go off and do anaesthetics. So after I qualified as a doctor, I decided to pursue a career in anaesthetics. Got married. My wife was trained to be a GP, and anaesthetics was a lot of fun, a lot of excitement. When you were on call, you had your stethoscope around your neck, you were in your blues, you had your bleep next to your ear, and when you were on call, it wasn't sort of beep, beep, please phone this number. It was emergency, emergency, come down to trauma immediately. And it would be blaring out at you from the bleep. So you'd run down to wherever the emergency was, and invariably you'd be down in A&E, you'd be running down the corridor. At the other end, someone was shouting, "Who are you?" and you'd be saying, "Anaesthetic on call, anaesthetic on call." And they'd be putting their hands out like this to kind of direct you where they were going, because there wasn't even time to chat. And as you rushed into trauma, you'd see a patient lying on the bed. There'd be 8 sorts of doctors and nurses around. On the screen, you could see it was all flashing. There was some sort of ECG. SATs were down to 70%. The patient was going from grey to blue. And you're shouting, "What's the story? What's the story?" As the laryngoscope is brought to you, and you're putting the tube down and things. And as the tube went down, you bag them. You see the chest rise, you're whacking adrenaline into the patient to try and get the blood pressure back up again. And as the chest starts to rise and as the blood pressure starts to come back, there was this sort of sense of relief around the room. And then invariably, the medical registrar was then spending the next 5 hours trying to find an intensive care bed whilst you kept the person alive down in A&E. The story was almost always some young person, girl or boy, who'd fallen out, taken an overdose, collapse with a GCS of 3 and needing resuscitation. And that was what was happening, and that was typically the on-call of an anaesthetist. Very exciting, a lot of fun, a lot of adrenaline, but you came home at 8 o'clock or 9 o'clock in the morning absolutely exhausted. And then I'd say to my wife, "Oh, I've saved this life and saved that life, and what about you?" And she said, "Oh, well, I had a couple of calls and a couple of Venflons to do, but as a GP trainee, you didn't really have to do as much." She turned around and said, "This is great when you're a trainee, but Amir, once you become a father, once you have children, are you still going to be working at that pace? How's it going to work?" And it started to dawn on me that maybe I need to consider a different career. And that's how I ended up thinking about general practice and decided to go into general practice.
Do you think that was a good decision overall to move from a very high-paced environment where there's so much action going on, you're on call, you're at the very stakes where it's life or death, to something where you are in your own office, you're in general practice, and the hours may be a bit more flexible, especially if you're somebody who's trying to be a part of a family and things. When you look back on it, do you think that you made the right decision?
So my parents were disappointed with me when I decided to go into general practice, especially because they'd seen what was going on in general practice even back then. They saw that there was becoming less and less respect for GPs. There was more and more abuse that was being felt by patients, to an extent by the system. It was nowhere near as bad as it is now. And they felt that my future would have been better in a hospital-type environment. That was back then. This is my 25th year now as a GP. And I look back at the last 25 years and look at the opportunities that I've had now as a GP, the way I've been able to touch people's lives and make a difference, not just at a sort of in my own job, but in terms of the wider system, right across the NHS and beyond, that I simply do not think I would have been able to do if I'd done anything else, if I'd remained as an anaesthetist, for instance. So I think I'm very, very blessed. And my parents also eventually came round to the idea and saying, Amir, how did you do what you've done as a GP in a small little GP practice, and yet you've managed to change people's lives and the world in my own little way?
Can we go a little bit more into these opportunities that you've mentioned? What were the biggest sort of memories and moments that you've captured as being a general practitioner?
Well, I'd like to pull back a little bit, actually, and say, what about medicine? Why did I choose medicine? I guess many people that are listening to this podcast are wondering, why are we choosing medicine? What's it for? As I say, I grew up in a household of doctors. All my extended family are doctors. It was relatively easy for me to choose that path because everyone did it. I was very fortunate and blessed in that way. But I also had an interest in IT, and I got myself a ZX Spectrum, which was a computer that you could program using something called BASIC. And I remember when I was 14 years old, I was in a French class, and the teacher had asked me what the French word for boy was. And I just could not remember the word le garçon, and it really upset me, because I sat there thinking, 2 years from now, I'm going to be doing my O-levels, which is the equivalent of GCSEs. I'm expected to get A grades if I want to get into medicine, and yet I can't even remember the French word for boy. What's going on here? But because I knew how to program computers, I went home and I created a little database. And in your French textbooks at the back, you have the English words and then the French words and translations. So I created a database, typed in all the words in the back of the book, and then this program would randomly generate 10 words from all the A's, B's, C's, either in English or in French or across the whole thing. And then before I went to sleep, I would run the program for about 10-15 minutes. It would just generate random words, and I'd have to then type them out. Well, I went from not knowing the word le garçon, and within 2 or 3 weeks, every time the teacher put the hand up and asked a word, I put my hand up straight away and answer it. And everybody in the class turned around and said, how have you done that? And I go, oh, it's a computer. And they didn't understand how. And for the first time, what I learned was that computers could actually be used to help us improve ourselves, to improve our knowledge and things. And of course, I became more and more interested in programming. I learned machine code. And my parents could see that I had a real interest in IT. Even when I went off to do my A-levels, I did mathematics, physics, chemistry, and biology. And my strong subjects were mathematics and physics, and my weak subjects was chemistry and biology. And biology in particular, I was terrible at trying to remember the 10 causes of this, that, and the other. And so I had a choice when I was doing my A-levels of either going into medicine or going into IT. My parents wanted me to go into IT because they saw what was going on in medicine and where it was all heading, and it wasn't looking good. But for me, it came down to, I just saw IT as a tool. It's a bit like a pen. Yes, it might be very flashy, it might look very good, but ultimately it's just a pen, it's just a way of doing something. Whereas as a doctor, I touched people's lives, I made a difference. I used that pen in order to prescribe something, in order to refer them or to reassure them. And for me, that felt like a higher calling. So that was why I chose to do medicine.
Beautiful, yeah. I'd like to do a little bit of myth busting with you, Dr. Hannan. So this old phrase, jack of all trades, master of none, seems to be something that's often attached to the life of a GP. Would you say that's a fair way to describe somebody who goes down your career path?
Yes and no. I remember after I'd qualified as a GP, I was very, very fortunate, and I was invited to join the Clinical Leaders Network, which was a network of aspiring leaders as well as those who were already in leadership positions. And the whole idea was to take around 50 or 60 different people from different specialties and put them in a room, and then we would do things like action learning sets where they would invite a speaker to come and talk about whatever the issue was. Let's say it was about urgent care, or whether it was about reorganising, stroke services, or introducing choose and book and things. And the whole idea was they would give a talk about something, the specialist expert, and then we would then sit down around a table and discuss it around what it all meant. And I remember very early on, in fact probably one of the first meetings I went to, when each person introduced themselves, one person said, I'm an expert in orthopedics. Another one said, I'm an expert in dermatology. Another one said, I'm an expert in physiotherapy. And then it came to me and I said, I'm an expert in general practice. And they all looked at me strangely. And they said, oh, never heard that before. And I said, well, if you guys can say you're an expert in this, that, and the other, well, I think I'll say I'm an expert in general practice.
Mm-hmm. And how did that go?
They sort of smiled and they thought, that sounds quite good. And then we moved on because we were all clinical leaders. It really didn't matter.
Yeah.
It's not really about what you say, it's about what you do.
Mm-hmm.
It's about how you come across. And I think we all have a role to play in supporting patient care, whether you are that orthopaedic surgeon, that anaesthetist, that physiotherapist, that nurse, or that doctor or GP for that matter.
Do you feel as though, as a GP, you are in a much better position to inform members of the public on general health issues compared to, say, a specialist who knows a lot about a particular niche?
I remember a story where we were at a wedding, and you can imagine everyone sitting around the table eating food, and then suddenly someone swallows something and it gets stuck in the throat. And just at that moment when that happened, there was a consultant anaesthetist sat next to them, and they immediately picked up a knife and they were about to do an emergency trachea.
No.
But fortunately, on the other side was a GP who decided, actually, we don't need to do that. Let's do the Heimlich maneuver.
Mm-hmm.
And fortunately, they were able to save the person. Doesn't mean that one is more important than the other. But what I would say that as a GP, because we are in the community, living with the people where they live, we have a broader view of things that isn't quite the same as if you're inside a hospital and you've got all the equipment around you and all the monitoring things and all the rest of it. I think as a GP, we are trained to not just look at that blood test result or that blood pressure reading or even just what the patient says, but thinking very holistically about the family, the work circumstances, the community they're in, looking at all the resources and coming together. I think context is really important. Clearly, if you've collapsed unconscious and you're in VF arrest, then you need all the advanced life support and the emergency drugs that I was trained to use in that environment. As a GP, our emergencies are more about the crisis of obesity, the rise of diabetes, the increase in mental health problems. And clearly, for many of these things, a drug is not the answer. So you think more holistically, but both are just as important.
That's really fascinating. I'd like to touch upon that a little bit later on in the podcast. But now I want to shift our attention a little bit towards your career, specifically your practice in Hyde. As many people may know, this was previously owned by a very notorious, infamous previous doctor. Some of the viewers may know Harold Shipman. And so he's known for having committed a lot of atrocities in that region, over 200 patients killed directly through his work. And so obviously this put a huge stain on that local area for the people. And being a doctor who's going to move in and replace somebody like that, what was it like?
Well, it wasn't glamorous, I can tell you. I'd just qualified, finished my training, my wife was pregnant, she'd just had a baby. Most people, even back then, when they qualified, would go off and do a locum job. But she'd turn around and said, look, Amir, you're a father now, you've got responsibilities. I need to know that you're going to have a regular income, so you need to register and get yourself a permanent job. She had an uncle who worked in Cheshire, and he was a GP as well. So she suggested that we perhaps look for a job in Cheshire. Now, little did I know that Cheshire wasn't sort of a circular area, but it was more like a donut shape. And in the local British Medical Journal that we were looking through, there was a job that had come up in Cheshire. It was at Market Street Surgery. And I said, oh, look, there's a job here going. Shall we apply for it? So she said, yeah, let's do that. So I rang up, and I remember sitting in bed with her next to me watching. And I rang the surgery, spoke to the practice manager, asked if there was a job going. He said yes. And then I said, well, where do you want me to send my CV? And he sort of said the address, 21 Market Street, Hyde, Cheshire. I sort of dutifully wrote that down on a piece of paper. I'm not very good at multitasking, so I didn't really register what the address was. Put the phone down, saying to my wife, there, well, I've done it. And she said, isn't that where Shipman used to be? And I looked at it and I thought, God, yes, it is. So I called back and I said, is this where Shipman used to be? And at that moment, he said, yes, is that a problem? Now, I had some great trainers, and one of my GP trainers had said to me that as a GP, you're not expected to know everything about everything. But what you should be able to do is be able to work out whether it's something that you can deal with it or whether you can signpost it to somebody else. And it really doesn't matter whether you're in a market town in the UK or whether you're downtown in, let's say, Ukraine, where a war is going on, or whether you're in deep-seated Africa. As a GP, you should still be able to work out what to do next. And so when I heard that this was Shipman's practice, my brain went into overdrive at 1,000,000 miles an hour. I started to work through what does that mean. And I figured out, said, well, no one's expecting me to do any heroics. I'm still going to be a GP. I'm still going to be dealing with people that have got pregnant, people that have been diagnosed with hypertension or diabetes, and people that die. Yes, there may be a little bit more mental health stuff, but again, they're not expecting me to know the ins and outs of details. I expect there'll be support there available. So it wasn't a problem for me.
So you stepped into a location during the aftermath of, a lot of undescribable events that went on following Shipman. What was it really like in terms of the people's perspective? What did you notice about them? Was there a lot of, as you mentioned, sort of like mental health crises that you noticed? Or was there a lack of trust from the patients towards you?
So it didn't really hit home to me until the day before I was due to start. So remember, I've just done all my training, completed my medical school, completed my training as a GP. This is my first job. And the day before I started, I was watching BBC News with my wife, and you know how it comes up with breaking news and the new item comes in? So I had breaking news on, and the cameras were in the waiting room of 21 Market Street in Hyde. And if you can imagine a picture where elderly English people were sat on the floor cross-legged, and they were angry. And the reason they were angry was because Shipman had got arrested 2 years previously. There'd been a locum who'd been working there for 2 years, and they were all in shock with what had happened. They couldn't believe it initially. They thought it was all a big mistake. And then when it turned out that he really had, and they think he's murdered somewhere between 250 to 500 people, he's one of the most prolific murderers in the world. When it became apparent that he was not going to come back, that's when the job was made available. They all thought the locum was going to get the job. But instead, here was this new doctor that had just qualified that was taking that post. Well, they were very angry. It'd been bad enough for them to have to deal with having Shipman there, but then to think that the doctor that had supported them for 2 years was now no longer going to be their doctor, and instead there was going to be this new, bright, young thing that was going to be coming. You can imagine that didn't go down well. I remember looking at my wife, and both of us saying, oh my God, is that the war zone that we're walking into? And it really was a war zone. When they first came, they always thought that this new doctor was going to make his millions, sell the stories, tell everyone, spill the beans on what had happened. And I promised them then, just as I would now, that as a doctor, whatever we talk about remains confidential. So I'm never going to share the stories of what I heard during those first 2-3 years. But what I would say to you is that if you knew what I know, you won't be doing anything other than what I'm doing at the moment. There's no doubt about that. And it was challenging because in the first couple of years, patients were angry. They were angry with the politicians. They were angry with the healthcare system. They were angry with the health boards. They were angry with the local GPs. They were angry with everybody. And often that anger would be translated to me. And they'd say things like, well, why should I trust you when we trusted Shipman and he did what he did? And my answer to that was, I appreciate that, but I can only be held to account with what you tell me. If you choose not to tell me things, then how can I know those things? But it was very, very hard work. And imagine every day coming into work and patients being angry with you because they were struggling with it. But I remember sort of 3 years into the job, 3 years of all this anger, and there was a patient who was asking some detail about something that was in their record. And I turned the screen so the patient could see the same information as I could. And I'm a real stickler for detail. 90% of communication is non-verbal. And so I'm constantly observing. And as I turned the screen, I saw the flicker of a smile, just like you're smiling now, on the patient's face. And I'd not seen that before, because normally it was just anger, anger, anger. And the patient said to me, "Are you allowed to do that, doctor? i.e., are you allowed to turn the screen so that I can see the information about me?" Now, of course, even back then, people used to talk about shared care and talked about building partnerships with patients and things. And although no one had ever said that you can't share, that you can share the information, they hadn't said you can't either. And I said, well, although no one's ever said this, I don't see why I can't, because I've got nothing to hide. You know, we don't know why Shipman did what he did, but what we do know is that the last patient that he murdered, he'd changed their medical record. He'd added into the record the fact that she had ischemic heart disease, and then he'd claimed that she'd had a heart attack. And the family were very surprised at this, because they never knew anything about heart disease, and she'd never mentioned it to them. She was the ex-mayoress of Hyde. And that stuck in my mind, and I sat there thinking, well, if this is your information, I've got nothing to hide from you, so why don't I share this information so that you can see what I'm thinking? You might not understand it. It's my job to try and help you, but it's possible that if you're looking at the same information as I am, you might be able to see things that I haven't seen, and we can build what I call a partnership of trust, this very, very special relationship that a patient has with a clinician, but with the medical record, the information about them shared so they can see the same information as we can. And if I can provide other information to help them understand what that means, we move into this very, very magical space called the partnership of trust.
Beautiful. So you really faced the heat, a lot of backlash. It's the kind of anger that you fear, especially as a young doctor going into a new unknown area. And so perhaps for the listeners, what are some pieces of advice that you could give to future doctors who may deal with a lot of anger or distrust from patients? How can we approach it well in a sensitive and caring way?
I think the first thing is to recognize it and to become more in tune with your own feelings and emotions, constantly thinking about how you can improve yourself, expanding your knowledge, expanding your skills, thinking about your attitude. I thought long and hard about that moment that I described earlier when I said to my dad, see him in court, because I wondered whether that was a weakness in my own attitude. Was that the wrong thing to do? Here's a person who's asking for help, and my response was an immediate, see them in court. And I felt it was the right thing to do, so I was questioning it, but nonetheless, keep questioning yourself. So that's the first thing. I think the second thing is that people, generally speaking, are not just angry. We don't come into the world angry. People have all sorts of challenges, all sorts of difficulties that they're facing, whether it's health issues, whether it's issues to do with their family, whether it's to do with their finances, maybe it's their neighborhood, maybe it's their worldview. You know, they're angry about whatever else is going on. And that can sometimes translate into how they're feeling. Our job is to try and understand that, to consider whether there is any sort of medical causes for why this might be the case, and if there's any way of kind of helping to manage that. As an example, one of the things that we have in our practice is a chaplain. It's not a routine thing that is happening. Chaplains traditionally were in hospital, but as care is now moving away from hospitals into the community, and people want to die at home, it naturally makes sense that we should have a chaplaincy service that's based in the community rather than a hospital setting. And certainly over the last few years we've had a number of patients who've died. Families have really struggled with that and the grief that comes with it and bereavement, and we've referred them to the chaplain. And we've explained that they're not counsellors, they're not medically qualified, they're chaplains. And they've said, well, and also they'll treat anybody or see anybody. So you don't have to be a religious person. She happens to be of the Christian faith, but I've certainly sent Muslims and Hindus and Sikhs and people even don't have faith to her. People have wondered how will that benefit, and yet by going and talking to that trained professional in that 1 hour, they've been able to empathise with them and help them to move forwards in their own lives. So there are many different ways that we can deal with it.
You seem to embody this idea of interdependence. Can you talk to us a little bit more about that and what that means to you?
So traditionally, patients were told that you need to go to your doctor to get not just advice, but permission to be able to do things. And that's because understandably, we've worked very, very hard to do well in our school, in our studies, go to university, do a 5 or 6 year degree, and then spend another perhaps 5, 6 years training in a postgraduate setting in order to perfect our technique and our art. The idea that a patient who's not done any of that is suddenly going to look after themselves sounds very alien. And so traditionally most people think that you need to go and see a doctor in order to even get permission to take paracetamol. Now that's always seemed very odd to me, very alien to me. I believe, and there are very famous people out there in the past who believe that we're all doctors in some way or another. We can look after ourselves. But in order to do that, we need to develop that skill, that knowledge, and whatnot. I think in the last sort of decade or so, as more and more stories have come out where doctors have made mistakes and we aren't the fountain of all knowledge and we don't know everything about everything, some patients have lost trust in doctors and decided, oh, I don't need doctors anymore. I can be independent of them and I can decide what to do. And I can read the very same guidance that the doctors have. I can read the NICE guidance or clinical knowledge summaries or go on the internet. And latterly, I guess, it's let's go and ask ChatGPT or equivalent and think that will become the fountain of knowledge for them. And to an extent, I can see why people would start to think they've become independent. But there's one big problem in all this. And the big problem is, of course, that we're going to die. Every single one of us is going to die one day. So even if you're relying on ChatGPT or relying on your own knowledge and experience, there's going to come a point when whatever you're doing is not working. You know, you're still losing weight, you're still not able to climb up that hill, you're still feeling breathless or whatever it might be. And everybody comes to a point when they've exhausted everything that they can do, and that's when they want to turn for help. And that's why I think that we still have a role as doctors to be able to support patients at a point when they feel that they've done as much as they can. And for me, that's what interdependency is all about. It's what Stephen Covey talks about in The 7 Habits. Some people might choose to do it very, very early on. Some people might leave it till death's door. I'd like to think that people educate themselves. Nelson Mandela said, education is the most powerful weapon which you can use to change the world. That education is not just for us as doctors, it's also for patients and the public. And if they can learn more and more about the things that they can do to help themselves, what normal is for themselves, and then when things are not working the way they expect or they're not sure about, to perhaps come in and have a chat, I think that's probably the best place to be in.
In this day and age, as a GP, you mentioned that we have to oversee more than just conditions that require some drugs to treat. You say that we are in a battle against whether it's obesity, the mental health crisis, and other things, whatnot, tied into perhaps diabetes, etc., perhaps chronic conditions. And so you mentioned about viewing humans holistically and dealing with people in that way. How do you sort of navigate that challenge?
So for me, I think as a GP, I think that we should be able to responsibly share information with patients. It does not make any sense to me that a patient is expected to look after their own health but not see the data, not see the information about them. I remember very well, about 3 years after I qualified, a Bengali patient in his late 40s, early 50s came to see me. The nurse had asked him to come and see me. And my opening question was, how's your diabetes going? His English wasn't great, but his response completely freaked me out. All my training as a medical student, all my training as a junior doctor, by then I'd qualified as a GP, I'd been a GP 3 years, had not prepared me for the answer that he gave. And his answer was very simple. He just said, it's fine. Now you might think, well, what's so difficult about understanding that? The problem was that his HbA1c, which is one of the markers that we use to monitor someone's control of their diabetes, normal is less than 42. If it's over 48, it's diabetes, if it's on 2 occasions. Generally speaking, you've got good control if your HbA1c is between 48 and 54. In our practice, if you've got poor control, it's around the 60-65 mark. This chap's HbA1c was about 140, 150. It was completely off the scale. And not only that, but it had been like that for the last 5 or 6 years. And the nurse had asked me to come and see him. You could say, well, maybe our doctors and nurses were not managing him very well. They weren't treating him right. They were just leaving him, expecting him to try and just fend for himself. But we are an outstanding GP practice. We're a training practice. We take pride in delivering high-quality care. And if you looked at his notes, you'd have seen that every 3 months he'd been seen by different doctors and nurses, all of whom had stepped up his medication, started him first-line treatment, second-line treatment, third-line treatment, and yet his control had remained incredibly poor. Now, what I could also see from the computer was that he had never ordered a single prescription in the last 9 months. It was like he was coming to the doctors were giving him a prescription, he was walking out the door, he was ripping up the prescription, throwing it in the bin, and in the meantime injecting mangoes into his bloodstream, because how else can you get blood sugars as high as that? And then every 3 months coming back to the doctors again to go through the whole process. And that's why I did not know what to do with this person. Now, that was in 2003. In 2004, a year later, I found out there was a way for patients to be able to see the very same information as what we could. Remember, this patient had walked into the surgery. He was not complaining of chest pains. He was not complaining of being on dialysis. He wasn't going blind. He didn't have a leg amputated. He was fine. That's why he said, I'm fine. But of course, I could see from the records, I could see from his test results that he wasn't fine. And the problem was, well, how would he get to know that? Which is why it does not make sense to me that if you've got a long-term condition, that you should be able to look at your medical record. You should be able to see the same information as what the doctors and nurses can. There's a lot of studies that have shown that that patients will only remember 10% or 3 bits of information that a doctor or nurse has told them. And that's been done as surveys in general practice as well as in hospital medicine. It's been done here in the UK and it's also been done abroad. A researcher sat with the patient in the waiting room. The patient has gone in, seen the doctor, had a 10-15-minute consultation. They've literally walked out, and when the researchers asked them, can you tell me what's been said? The response has been, on average, 10% or 3 bits of information. So if I told you, I'd like you to start taking metformin 3 times a day with a meal and to come back in a month's time, I've already given you 4 bits of information, and the average person only remembers 3. I think it's daft now in 2025, when even here in the UK, 98% of the population has access to the internet, that we are still expecting people to try and remember things. What we should be doing is saying, I'm going to write down all the things that are important. I want you to read them afterwards. I want you to go home. I want you to talk to your family about it, or whoever you trust, because in every family, there's a family health manager. There's one person who tends to look after everybody else. If that person knows what the doctor or nurse has said, then maybe, just maybe, that person might then say, look, these are the tablets you need to take. This is what you need to change in terms of the food that you're eating. So the first thing is, I want patients to be able to access their medical records wherever they are throughout the world. Secondly, it's not just about access, but it's about understanding. I've just given you an explanation what HbA1c is, in case you don't know what that means. We need to provide them with trusted information to help them understand what those records are. We need to build that relationship, that partnership of trust I've talked about, so that if a patient doesn't understand or gets scared or doesn't know what to do, they can safety net and they can come back to a safe place, the practice, where they can talk to somebody who knows them. So I'm a big believer in continuity of care. Evidence shows that if a patient sees a doctor who they've known for 20 years, then their outcomes are 30% better than if they see anybody else. So my presence in the surgery is also really, really important to help patients to get the best care.
Brilliant. So, your career, you have overcome some adversities in terms of taking over a difficult practice, right, in terms of the history. And then you went on, I believe, to achieve an MBE. How did you do that?
So, I don't really know is the truthful answer. It's a dark science, if that's the right word to use, or art, I should say, really, because you don't put yourself forwards for an MBE. Other people who will always remain nameless put you forwards for it. There is a very rigorous process that the government goes through, because it is a government honour, if you like, or an award. Typically, it takes about 2 or 3 years of background checks on that individual to see whether they are worthy of such an honour. And back in 2021, about 3 weeks before Christmas, I got a phone call. In fact, actually, I got an email saying that you've been awarded an MBE. I thought it was one of those strange messages that you get from Africa, deep into Africa, and a bit of a con. But I followed up on it, fortunately, and it did turn out that it was the case. And I was fortunate enough to go down to Windsor Castle and meet Princess Anne, and she awarded me the MBE. The MBE was awarded to me because of my services to general practice. Deep down, I believe in general practice. I believe general practice is the jewel in the crown of the NHS. It's what's helped to sustain the health system of the country, and is something that I feel very passionately about. I love being a GP. I love doing what I'm doing. And ultimately, I guess the powers to be wanted to award me for this. Along the way, of course, I've had to deal with the shipment things. Patients had lost complete trust in their doctor, in the practice, in the healthcare system. Right across the world, people have heard of Shipman and who he was. And I did my little part, working with my patients, working with the practice, working with our patient participation group to rebuild that trust, such that if you come to Hyde today and if you talk to my patients, they'll speak very fondly that we've managed to restore that trust, so you don't hear as much about the stories. That does not mean that everything is hunky-dory. If your grandmother or grandfather had been murdered by Shipman 25 years down the line, you are still going to be thinking about it, so it never goes away. I'm still dealing with the consequences of what he did.
And for somebody who has made such a incredible local impact, which has resonated globally, how could you advise, upcoming doctors to also follow your footsteps and continue to make a global impact?
Firstly, as I've described, I wanted to be a doctor. I'd made a decision not to do general practice, and then I came back to it. And I'm so glad I did, because of the huge opportunities that I've been given as a consequence of that. I don't see it as a job. I love what I do. I know I'm in a very fortunate position. As a GP, you get to see all your patients, and I would imagine that 95% of people just do a job because it pays the bills, it pays the mortgage, or whatever it might be. A lot of people feel very unhappy with what they're doing. I'm in the fortunate bracket that I love what I do. I come to work excited, exhilarated, sometimes worrying about what may go wrong, but not paralyzing me. Instead, it actually pushes me forwards. So when things don't go wrong, don't go right, I'll think about what I could have done differently. How could I have made it better? I work with a great team. I've got a fantastic set of doctors, nurses. I have a quote: managers provide the context for patients and clinicians to excel. Because I spend my whole time with patients, in effect, they are my doctor. They're looking after me. So sometimes patients say, "Oh, Dr Hannan, you look tired today. Are you going on holiday? Are you doing this, that, and the other?" And it's very strange. So they're giving me counselling, even though they've come to see me. It's a lovely, lovely, lovely relationship. So that's so enjoy what you do. Feel passionate about it. Continue to keep striving to improve. I see medical students who seem burnt out, who are worried about what they're going to do and where the future lies. They're worried about things like artificial intelligence, and will there even be a job? Will ChatGPT remove the need for doctors? I don't believe so. I think there's something much, much more powerful than artificial intelligence, and I call that human intelligence. And what you're listening to at the moment is a human being talking about the feelings and emotions as well as the knowledge. And it all comes together in that consulting room, where you are helping that patient. When a patient comes in and they're frightened and they're scared and they don't know what to do and it's not looking good, sometimes just sitting and just listening to them. I may not have the answers. I may not be able to fix them. Like I say, each and every one of us is going to die one day. There isn't an answer for everything, but you're continually striving, you're supporting, you're helping that individual. And even if they come in and just express their fears and walk out again, as long as when they walk out, you've learned something more about that person or they've learned something from you, it's a worthwhile thing. And I think that's why patients value us. That's why they come to see us. Even though they might We might not be able to fix whatever it is that they're trying to go through. It's being with them. I don't believe computers will ever be able to do that.
Really fascinating insight. And so you've touched upon the future, and so I want to delve into that world now. Why do you think the NHS really struggles to retain so many doctors once they graduate? Because there seems to be some element of medical students just being raring to go. As soon as they're done with the degree, they want to go to Australia or Canada, America, wherever it is. Why not UK?
If we start at if we were looking at the beginning of the 20th century, the average life expectancy for an individual was about 40 years of age. So I would probably have been a granddad by now, or more likely 6 foot under and dead. Of course, over the last 120 years or so, we've made massive strides. I wish I could say it was to do with medical care. It's not. The number one reason why people are living longer is because of clean water. The second most significant factor is vaccinations. That's helping to save people's lives. Of course, there are things that we're doing in healthcare that means that 25 years ago, if you had a heart attack, you were likely to die. Today, because of things like rapid access chest pain clinics, as soon as you start to get a bit of chest pain or a bit of breathlessness, we refer you to the cardiologist. They put you on a treadmill. They start you on treatments. In fact, even before that, as a GP, we're checking people's blood pressures and cholesterol and starting them on statins, starting them on blood pressure lowering therapies, such that people are much less likely to die of heart attacks and strokes than they did 20 years ago. The consequence of that is people are living a lot longer. That is, I think, a huge success for society, for civilization, that people are now living to 100 and beyond. Which is, if we take it another way, back in the 1960s, I think there was only about a few thousand people that lived to 100. Now there's over 125,000 people living over 100 years of age. So that's a success story. That's something for us to celebrate. However, with that comes a whole load of other challenges. People are now living with their heart attack. They're living with their stroke. They're increasingly frail. They've got comorbidities. That means that they're taking multiple medications that may interact with each other and makes things more difficult. As people are living longer, there's fewer people who are in the workforce. So there's fewer of us who are able to look after those that are older. Monies are tight, there's no doubt about it. Doctors can earn more money in other parts of the world. You've mentioned Canada, Australia, America, and so on. But I'm chair of the World Health Innovation Summit. I've got a chief executive and a team of people that are working on all 5 continents of the world. And I can tell you, every single healthcare system in the world is in trouble. Now, you might even sit there thinking, well, what about Qatar? What about in the Middle East where there's a lot of money? And yep, sure, there is. They've got new hospitals. They might not have waiting lists like we do. But they've got their own challenges. The number of people smoking, the number of people who are putting on weight and then developing obesity and diabetes is through the roof. The number of people that are on medications to try and manage their diabetes is increasing. When a patient comes to me and says, Dr. Hannan, I want you to fix my diabetes, I turn around and say, listen, there's 5,000 other GP practices out there. Go and join one of them. I cannot fix your diabetes. And I say that because there are thousands and thousands of decisions that we make every single day that will impact on our chances of developing these conditions. For instance, I chose to park my car today about 15 minutes away from this place so that I could actually go and walk 15 minutes instead of just parking right in front of the studio and coming in. I chose not to have sugar in my coffee. I chose to join parkrun this morning, so I went for a parkrun this morning. And everything that I know as a GP is telling me that the answers don't lie with tablets or counselling or hospital treatments and things. It's about looking after ourselves, our own health. And that's why, as chair of the World Health Innovation Summit, it's about improving our health and well-being. Our mission is to empower individuals so that they can enjoy their health and well-being. And I think we need to move away from a disease service to a health service, one which promotes health and well-being. Every single healthcare system in the world has got to move towards that. Now, what does that mean for me and you? as individuals, as people. Just like I've described what I'm doing, everyone else needs to do the same. It's not enough to say, I'm on statins, I'm on a blood pressure tablet, I can get Mounjaro to reduce my weight and improve my diabetes and things. We've actually got to start thinking about how can we change our lifestyle into one that's much more positive. And in fact, 6 years ago, I was sat at my desk. It was 7:30 at night. Everyone else had gone. I was looking through my test results for my patients. And we, in our practice of 13,000 patients, are diagnosing 1 to 3 people with diabetes every single day and 3 to 5 people with pre-diabetes every day. I've already mentioned that everyone in my family are doctors, but the other thing that I'm not so proud of is everyone in my family also has diabetes. And even though I might be sitting there thinking I'm making a difference for all these patients and helping them, I sat there thinking, but what am I doing for myself? In the average day, from morning to night, I might only walk about 200 to 800 steps. I get in my car, I drive into work, I park my car under the surgery, I walk upstairs, go into my room, fire up the laptop, I've got 3 screens in front of me, and then I'm firmly placed from morning till night looking at those, looking at the computer screen. If you look around you, look at the people that are working in your hospital, in your GP surgery, in your community clinics. Do they look like a healthy bunch of people, or do they look unhealthy? And you start thinking, are these people storing up problems in the future? And then so 6 years ago, I came home, my wife's a GP, and I said to her, dear, I'm going to start a walking group. And she said, what for, Amir? And I said, because I've got a feeling that there'll be other people that are going to enjoy walking just like I do. And it's about bringing people together. So we set up South Manchester Muslim Walking Group. South Manchester is where I live. Muslim, well, that's my identity. It's a walking group. But it's not just for people in South Manchester. We've had people from all over the world come. It's not just for Muslims. Non-Muslims can come along as well. And it's from everywhere. And we go for a walk every Saturday, every Sunday around Greater Manchester and beyond. And there are 3 main purposes to it. The first is to improve our own health and well-being, to help prevent things like diabetes, blood pressure, stress, back problems and things. But there's a second one which I see as a GP. Increasingly I see the fathers are busy doing one thing, the mothers are in the kitchen, the children are just playing video games, and the family unit is breaking down. Actually, walking is one of the very few activities where the whole family can come together. Parents, grandparents, grandchildren, children can all come together and go for a walk. And then thirdly, increasingly I'm finding if I want to see my neighbours or friends, it's a bit of a standing joke, but I'm going to see them not walking down the high street, but rather at Jumeirah Beach in Dubai at Christmas. And I kid you not, the number of times I've been sat in a hotel on a beach talking to the person next to me, where are you from? The UK, whereabouts? Manchester. And before you know it, they live 2 streets away. And I'm sitting there thinking, why am I travelling thousands of miles away, staying in a ridiculously expensive hotel in order to see somebody who's so nice? And so by going on these walks, families can come together and we can get to meet each other. It's that social aspect that I think is also really, really important, not just our physical and mental health. And I think also increasingly that spiritual side is really, really important as well. That sense of there is a bigger being, whatever it might be. It doesn't really matter. So we bring all those 4 components together, and it's South Manchester Muslim Walking Group. And as you can see, I've got my jumper on today.
Brilliant. And just to conclude here, what are some final pieces of advice that you would give? Perhaps you could do this by looking back at your own career and thinking back to what you could have changed or done differently, or just emphasize a bit more. What kind of things would you say to future GPs or to future doctors in order to really empower themselves and really make the most of their career?
I read a book a few years ago called The Secret, and I recommend everyone to read it. It's all about what is this secret that has enabled some of the greatest people in the world to achieve what they do. And the surprising truth is that you have everything that it takes to be the best that you can be. Okay, it's not about waiting for other people to do things, or that it's going to be by chance. Or yes, of course, you need to work with other people. The team is always greater than one person, and I've talked about my team, my practice, and whatnot. But there is something about you have got to recognise that if you go in there with a positive attitude, if you prepare and be the best that you can be. You can be anything you want. I've certainly seen that, looking back, the little me that, wanted to be a doctor and make a difference, and then became a GP in a small little surgery that no one would ever care about. And then sitting there thinking, now I'm sitting on top of the world as chair of the World Health Innovation Summit. My chief executive is traveling from country to country, having amazing conversations, whether it's in Brussels, whether it's in Doha, whether it's in Davos, etc. There's some really exciting things that are going to be coming in the next few years all over the world because of the work that we're doing. How does stuff like that happen? I never imagined that to be. So work hard, be the best you can be, keep your family close to you, work with your patients, not to them. Enjoy the work. Malcolm Gladwell talks about if you want to be an expert in anything, you need to spend 10,000 hours doing it. So if you want to be a GP, spend your time doing a GP. Don't believe what others say that you can dabble in this and dabble in that and dabble in other things. I still believe that there is a role for general practice. I still believe there's a role for GPs. Do the work. The rest will happen by itself.
Absolutely beautiful. Dr. Hannan, thank you very much.
Thank you.